And today, so good afternoon, everyone, again, and welcome again to our webinar. My name is Dr. Amina Rashid. So today, once again, we gather for a profoundly important discussion on on locally advanced cervical cancer as well as metastatic cervical cancer. And the reason we keep on talking about cervical cancer is, if you can remember the last presentation we had, I know Dr. Afrin talked about Globocan 2020 that estimated worldwide there were approximately 604,000 new cases of cervical cancer. And you can imagine that more than a half of those women died, and that comes to 342,000 deaths. And this is yearly. It's really, really, really a dire situation. And it's unbelievable because, and the reason I say it's unbelievable, it's because it's a cancer that we can prevent, isn't it? And what is even more baffling is that the majority of the new cases and the deaths occur in setups like ours in low middle income countries. So what does this mean? This means that women who say get diagnosed with cervical cancer in our setup, more than 90% of them will die. And that's really, really sad. So it means that today, if you get a diagnosis of cervical cancer, then more than 90% of those women will die. How sad is that for something that we can 100% prevent? So it's an honor to introduce our panel of distinguished experts, and they will guide us through the complexities of this condition called cervical cancer. So our first speaker today is Dr. Gabriel Ouma. He's a Gynaecological Oncology Fellow at Moi University, as well as Moi Teaching and Referral Hospital. He is an International Gynaecological Cancer Society Fellow and a member. He's a certified Kenya Medical and Practitioners Board, and he's an active member of Kenya Obstetrical and Gynecological Society. We are also privileged to have with us one of our mentors, Dr. Jesse Opakas. So Dr. Opakas is the current Clinical and Radiation Oncology Director. He is the head of Hemato-Oncology Directorate at Moi Teaching and Referral Hospital in Eldoret, Kenya. Dr. Opakas holds a master's degree from the University of Stellenbosch, South Africa. He's a fellow of the College of Radiation Oncologists of South Africa. And he is at the forefront of developing radiation therapy protocols for cervical cancer. He is a passionate advocate for patient-centered care, offering hope to many, and he does have a number of publications, the same with Dr. Ouma. So as we proceed, I want to, or rather, I would like to encourage you to engage with our speakers through questions. Please post your questions on the question and answer box. And let's listen to our speakers. I welcome Dr. Ouma, our first speaker. Dr. Gabriel, you can go ahead.
Thank you very much, Dr. Amina, for the wonderful introduction. So today I'll be taking us through locally advanced cervical cancer. And as Dr. Amina said, cervical cancer is one of the most, is actually the most common cancer in sub-Saharan Africa. It's also generally the leading cause of mortality, cancer-related death in Kenya. And around 35 to 50% of our patients, especially locally, present with locally advanced cervical cancer. And so in this presentation, I'll be just taking us through a sequel of what Dr. Afrin had taken us through last time of early cervical cancer. So around 19.7% of new cancer cases in Kenya, thus as per the 2020 reports, is actually cervical cancer. And it is actually the leading cause of cancer death in Kenya. And 9 women have been postulated to die daily of cervical cancer. That is as per the Globocan report. So vaccination of girls aged between 12 to 13 years against the 4 subtypes of HPV has been shown to reduce the risk of cervical cancer by up to around 87%. And WHO currently, as per the 2022 reports, generally recommend a 1 or 2 dose schedule for girls aged between 9 to 14 years. And they've also expanded the vaccination bracket to give girls between 15 to 25 what is called an expanded 2-dosing schedule or a catch-up dosing schedule. And this was in response to the low vaccine uptake that was seen, especially during the global COVID pandemic. So the primary target of vaccination is usually girls aged between 9 to 14 years and prior to the start of sexual activity. However, we have recommendations for secondary targets, including boys and older females, and this is recommended where feasible and affordable. There are countries like Australia that have actually been able to roll out vaccination for both boys and girls within the age group of 9 and 14, and generally the outcomes seem to be quite impressive. So in 2018, WHO came up with a global cervical cancer elimination strategy, targeting elimination of cervical cancer by 2030. And this was also in response to the global rise in the cervical cancer pandemic. And in these targets, generally, the target was 90% of girls to be fully vaccinated with the HPV vaccine by the age of 15. And all this is by 2030. And then 70% of women screened with high performance tests, that is at age 35 and 45, and 90% of women with precancer treated, and 90% of women who were found to have invasive cases adequately managed. So what has been the milestones of HPV vaccination and surveillance program ever since it was initiated in the year 2008? So generally, the bivalent vaccine was introduced routinely for girls aged between 12 to 13 years and girls aged up to 18 years for the first 3 years, and that was in 2008. So catch-up dose was given by the year around 2011. And then in the year 2012, the 4-valent vaccine was introduced. And this, as we know, generally covers for both the high-risk HPV and also the low-risk HPV subtypes that cause genital warts, that is HPV 6 and 11. And then by 2014, this was when the first evidence of decline in HPV prevalence was detected. And 2014 again, the 3-dose schedule was changed to 2-dose schedule. That is from evidence that actually giving 2 doses gives you similar immune response as giving 3 doses. So by 2016, this is when the first evidence of herd immunity was actually perceived. And this is whereby when you vaccinate a majority of the population, then the few who have been unable to get the vaccine are still protected. So in 2017, the vaccine was also rolled out for gay, bisexuals, and men who have sex with men. And in 2019, that's when now the universal rollout of HPV vaccination was actually launched. And this was actually in response to the global dramatic reductions in cervical cancer cases that were evidenced from the first group that were vaccinated in 2008. So by 2022, this is where now the 9-valent vaccine, otherwise called the Gardasil 9, was introduced, and this expanded the coverage for the HPV subtypes and to include around 87% of the HPVs that are responsible for cervical cancer cases. So in 2023, there were some landmark studies that were published, and these proved that actually giving now 1 dose gives you almost an equal immune response as compared to 2. So you remember we started by 3-dose schedule, which was now reduced to 2 in 2014. And then almost 9 to 10 years later, we reduced this to a 1-dose schedule. And I think one of the studies was actually conducted by Cambridge in Kenya, which actually gave some of the preliminary results to prove that a 1-dose schedule can actually give you similar efficacy. So in terms of global updates, by 2019, Australia had an HPV coverage of up to 80% in females and 76% in males. And this resulted in significant decline in vaccine type HPV infection and high-grade lesions. So of the over 400,000 girls aged between 12 and 13 years who were vaccinated in 2008 in Scotland, that is when the vaccine was rolled out, 0 cases of invasive cancer have been reported, and that is as per January 2024. So this was regardless of the number of bivalent doses received. And this according to the Public Health of Scotland. So in Kenya, by 2019, HPV vaccine was introduced to 10-year-olds. And by 2020, only 33% received the first dose, and 16% had actually returned for the second dose. This is as per Karanja et al. So by 2021, 77% of eligible girls received the first dose of HPV. However, only 31% actually returned to get the second dose. So in terms of Kenya's position on the WHO 2030 targets, as you can see from this graph, the target of 90% in terms of full vaccination, I think in Kenya, if we're using the two-dose schedule, we are only at 31%. That is as per 2021. If we are using the target of 70 for total screened by 2030, by 2021, we're actually at 31. And for those who tested positive using the VIA results, only 26% actually had some form of treatment. So we are doing not so well in terms of achieving the 2030 targets with only less than 6 years to go. So why do more patients present? As I'd said, 35 to up to 50% of our patients present with advanced disease, and majority being locally advanced. So why so? So generally, as you have seen, there's been low vaccine uptake over the years. And though we are having an improved trend, we also have a poor screening uptake. There's still a very high rate of teenage and adolescent pregnancy. I think the KDHS put it at around now 15%. There's also a very high HIV burden, and also the poverty burden in the society. We also have lack of experienced personnel. This includes screening, diagnostics, and even treatments. There's lack of infrastructure. Those are laboratories that can be able to process these tests that are being done, including the pap smears, and also a shortage of cytotechnicians, countrywide. There's also an unclear referral pathway whereby you can be able to do the biopsy, but then there is no clear referral guideline on how this biopsy specimen can be processed. Or in case a patient comes back with positive results, let's say from somewhere like, Narok or somewhere like Busia, then there has been not like a clear referral pathway for these patients to be able to get the care by the specific specialists that they need. There's also a gap in mentorship and continuous supervision. As we know, screening is something that gets better with time, and the more you do it, the more better you become with it. So there needs to be continuous supervision on and updates on whatever the world is doing currently. So in terms of staging, this is just a brief summary of the FIGO staging of 2018. And you can see for stage 1, cervical cancer is generally confined to the cervix. So when we'll be talking about locally advanced cervical cancer, we will talk about stage 1B3 and above. So 1B3 is generally considered to be bulky disease. And then stage 2, you can see for 2A, the tumor has extended to the upper 2/3 of the vagina. And then stage 2B, 2A is generally divided into 2A1, 2A2. So I think I'll get into the details later. And then stage 2B is whereby the tumor now extends to the parametrium. And then we have stage 3A, where the tumor is now extending to the lower third of the vagina. And then stage 3B is whereby now the tumor is extending laterally and posteriorly to the pelvic side walls. And this is whereby we end up having bilateral adenephrosis, renal dysfunction, non-functional kidneys. And then stage 3C is whereby now we have tumor extending or metastasizing to the lymph nodes. So 3C1 is to the pelvic lymph nodes, 3C2 is to the paraortic lymph nodes. And then stage 4A is where the tumor extends to the other adjacent pelvic structures, including the bladder, mucosa, and the rectum. So this is just a summary of whatever I've been able to talk about, but generally for the sake of clarity, when I'll be talking about locally advanced cervical cancer, it will be stage 1B3 to stage 4A disease. So this locally advanced cervical cancer has been associated with a higher rate of recurrence and worse survival than those patients who have early disease. And treatment is generally primary chemoradiation. I think later on in the presentation, I'll be able to clarify why. So for such patients, surgery is unlikely to be curative, and these patients will require adjuvant treatment, which has been shown to portend a higher incidence of morbidity. So for the 1B3 and 2A, 1B3, as I said, is tumor that is confined to the cervix, but it is bulky. That is a tumor size of more than 4 centimeters, but confined or limited to the cervix. And stage 2A is a tumor that now involves the upper 2/3 of the vagina. So these tumors are usually large and, a bit extensive. And in case you perform surgery for such cases, then they are likely to have high risk factors. And high risk factors, borrowing from the previous presentation, is whereby in the histopathology report, the patient has either positive lymph nodes, positive parametria, or positive margins from the pathology. And such patients, when they satisfy that criteria, then they are usually sent for adjuvant treatment. So if you perform surgery on these cases, then there is a higher rate of recurrence and there's a need for adjuvant chemoradiotherapy after surgery. And this usually gives the patients a worse morbidity profile. So generally a combination of surgery and then subsequently chemotherapy and radiotherapy is usually termed as trimodality treatment. And as I said earlier, it is associated with high morbidity for these patients. Therefore, if you are able to get just one treatment option for these patients, then you rather choose the one that is better, which is generally chemoradiation. So, however, there are centers that are generally do not have the services. There are countries, at least for us as Kenya, I think we have the benefit of having radiotherapy services. So for us, the standard of care would ideally be chemoradiation. But for centers or countries where they are still yet to procure the radiotherapy machines, then they can be able to look at other alternatives. So there have been studies that have been conducted to compare the outcomes of radical surgery versus radiotherapy for patients with stage 1B and 2A cervical cancer. So one of them was a landmark study by Landoni et al. In 1997. And his aim was to assess the 5-year survival and the rate and pattern of complications and recurrences associated with each treatment. So he randomized 343 patients, 170 who just had surgery, and 167 who went directly for radiotherapy. So as I'd said earlier, stage 1B and 2A are considered, bulky disease. Some people used to do surgery in the past for them. So in terms of outcome, the 5-year overall survival was identical between the two treatment arms at 83% and 74% for radiotherapy. And in terms of recurrent disease, it was also identical at 26 and 25%. But then in terms of the severe morbidity, that is the grade 3 and grade 4 adverse effects, you can see that patients who underwent surgery had a worse morbidity profile as compared to the patients who just went for radiotherapy directly. And this is majorly because most of these patients eventually had to have adjuvant treatment after the surgery because of the high risk factors that I talked about. So Landoni et al. Continued to follow these patients for up to 20 years. And I think by 2017, they released a 20-year update. And from the update, the 20-year overall survival was comparable between the two treatment arms, that is the surgery and the radiotherapy. However, combination of surgery plus radiotherapy had the worst morbidity. And that is why, as I'd said, it's better or preferred now to just go directly and give these patients concurrent chemoradiotherapy. So for stage 2B to 4A cervical cancer, 2B, as I'd said, is tumor that is now extending to the parametrium. And then all the way to 4A. 4A is now involving the adjacent pelvic structure, that is the bladder mucosa and the rectal mucosa. So for this subset of patients, CCRT is still the standard of care. And the addition of chemotherapy has been shown to improve or increase the overall survival by more than 15% and also reduce the risk of recurrence by up to 40% compared to giving radiotherapy alone. So for these patients, usually give weekly cisplatin at 40 milligrams per meter squared, and it acts as a radiosensitizer. It has several mechanisms of actions, one of them being that it creates an adduct, DNA adducts, and arrests most of these tumor cells in the G2 phase. So by doing so, G2 phase is one of the phases that are in the cell cycle that are most radiosensitive. So that means it exposes majority of the tumor cells to the radiation effect. The second mechanism of action is, cisplatin being positively charged binds to radiation ionized DNA molecules, preventing sublethal damage repair. So it generally inhibits the tumor cells from repopulating and causes eventual irreparable damage to the tumor cells. So there have been studies that have been conducted to just look at the efficacy of the combined chemotherapy plus radiotherapy vis-a-vis just giving radiotherapy alone for high-risk cervical cancer. And one of the studies was conducted by Patricia F. et al. In 2004. And the aim was to compare extended field radiotherapy versus just giving pelvic radiotherapy with concomitant 5-fluorouracil and cisplatin in women with locally advanced high-risk cervical cancer. So this was a prospective study between September 1990 and recruitment was between September 1990 and November 1997. So 403 women were randomly assigned to receive either extended field radiotherapy or combined chemo and radiotherapy with 5-fluorouracil and cisplatin. And in terms of outcomes, the 8-year overall survival for patients in the chemotherapy plus radiotherapy arms was significantly greater, whereby the patients who had chemotherapy plus radiotherapy had a 67% 8-year overall survival as compared to only 41% in patients who just received the extended field radiotherapy alone. So that is a 26% difference that just adding the chemotherapy gives. So the risk of recurrence was lowered by up to 51% in patients who are receiving the chemotherapy plus radiotherapy arm. However, the serious late complications were similar. If you look at the Kaplan-Meier estimates of overall survival for these patients, generally, just to summarize, you can see the patients who received chemotherapy plus radiotherapy generally had a better overall survival as compared to the patients who received radiotherapy alone. And you can see the survival was even superior in patients who had early stage disease, that is stage 1 and stage 2. So it was dramatically superior as compared to patients who had stage 3 and stage 4. So there was also another study now in 2006 by Peter Ross et al. And generally, Peter Ross wanted to look at different chemotherapy regimens because initially, as you had seen, they were giving 5-fluorouracil plus cisplatin. But then now he conducted a study to try and see whether adding more chemotherapy or reducing the number will give a difference in toxicity and survival. And for him, he had 3 treatment arms. Arm 1 was patients who had the radiosensitizers weekly cisplatin, and then arm 2 were given a 3-drug regimen, that is cisplatin, 5-fluorouracil, and hydroxyurea. And then the third arm had patients receiving hydroxyurea only as treatment. And in terms of outcome, as you can see, generally cisplatin had superior 10-year progression-free survival as compared to combination, the 3-drug regimen and hydroxyurea. And it also had superior 10-year overall survival as compared to the other regimens, but comparable to the 3-drug regimen. So in conclusion, the recommendation was that cisplatin-based concurrent chemoradiotherapy actually improves long-term progression-free survival and overall survival among locally advanced cervical cancer patients. And that is how now we move on from giving the 5-fluorouracil plus cisplatin to only giving cisplatin alone as a radiosensitizer. So when you get these patients who have locally advanced cervical cancer, ideally, the management remains the same. So you should just take a comprehensive history, including patient serostatus. You do a comprehensive general exam, assess, generally the things to look out for are wasting, pallor, because most of these patients will have had bleeding for quite a while and will be anemic. You check for lymph nodes, if they're palpable or not. You assess for dehydration. Patients who have 3B generally will have these protracted emesis, so you'll be able to stabilize them at that point. So you also are supposed to do a pelvic exam. And for this one, the main focus will be, on the location, the size, whether the tumor is extending to the lower third or limited to the upper two-thirds of the vagina, if there's any parametrial involvement. We also assess for pelvic side wall extension. And for this one, we have what is called the classical triad, whereby you get a patient who has either unilateral or bilateral lower limb swelling, low back pain, sciatica, that is pain radiating to the lower limb, or maybe they come with an imaging or an ultrasound that shows hydronephrosis. So that is generally, those triad generally gives you a hint that the patient actually has pelvic side wall extension, because these are now compression of the pelvic side wall structures by the tumor. So we also assess the rectal mucosa and see whether it is fixed or involved with the tumor. And we also check for any gross fistulas that may be involved. So in terms of investigations, the routine lab works, the CBC, renal function tests should generally be done. And for these patients, they require metastatic workup. So this includes imaging, an abdominopelvic CT scan will suffice, or an MRI for early disease, and then a chest X-ray to just rule out any metastasis to the lungs. Then an FDG PET scan for centers that can be able to do is also, used for the staging. So we're indicated, especially in patients who now present with side wall involvement and lower limb edema, then lower limb Doppler ultrasound can be done only when indicated. So for these patients, lymph node evaluation has been shown to impact on the stage and treatment. And in the past, previous gynecologists and gynaecologists will do, lymph node biopsies to just confirm involvement and guide in treatment. But then in 2018, FIGO incorporated imaging into the staging. And so currently, you don't really need to go ahead and do lymph node biopsy to put these patients on, treatment planning, the appropriate treatment plan. So you can actually just do imaging, and it will help you in terms of staging and designing the radiation fields. So in terms of imaging, on CT scan, or all these imaging modalities, there are things to look out for to give you a high index of suspicion that you're probably dealing with a metastatic node. So on CT scan, generally, is if you have a node that has a short axis of more than 10 millimeters, round or central necrosis, that one gives you a higher index of suspicion. On MRI, if the short axis is more than 8 millimeters, on morphology, round irregular edge, extracapsular invasion, central necrosis, or loss of lymph node structure, then that gives you a higher index of suspicion of tumor. On PET scan, if you have a short axis of more than 5 millimeters and a standardized uptake value of more than 2.5, or in case the FDG uptake is greater than that of surrounding tissue, then you highly suspect that you're dealing with metastasis. So in terms of renal insufficiency, as I said, these patients may present in stage 3B with the bilateral nephrosis and renal insufficiency. Ideally, you are supposed to image to determine whether the renal insufficiency is due to urinary tract obstruction or intrinsic renal disease. As I'd said earlier, these patients also present with protracted emesis, so they might be having pre-renal, deranged renal function. So you should be able to image. You can use an uncontracted CT scan or an MRI in case a patient has elevated serum creatinine, and ideally correct the obstruction prior to initiation of treatment. So there's been a study conducted by Ross et al. In 2010 to try and just estimate the significance of hydronephrosis and the impact of ureteral obstruction relief on the outcome in patients with stage 3B CS cervix. And it was a retrospective study. She analyzed 539 patients with stage 3B CS cervix, and these patients had an ECOG status of 2 or 3. So she classified the patients into 3. One is patients with stage 3B with no hydronephrosis. The second arm was patients who had hydronephrosis that was relieved using a stent or percutaneous nephrostomy. And then third, there were patients who had hydronephrosis without treatment of the ureteral obstruction. So the patients with hydronephrosis received similar doses of radiation and cisplatin-based chemotherapy. So in terms of outcomes, hydronephrosis generally was associated with worse performance status. And in terms of progression-free survival and 5-year overall survival, for patients who had their obstruction treated generally they had almost double uh, 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 5-year overall survival of 34 months as compared to 17 months in patients who had the obstruction not treated. And currently, I think this is one of the main challenges that we face as a country because of the shortage of interventional radiologists or the technicians who can be able to actually perform either nephrostomy tube insertion or ureteral stent placements. So majority of our patients who have stage 3B cervical cancer with bilateral adenomyosis and deranged renal functions end up doing quite poorly because we are unable to give this intervention. So at Moi Teaching and Referral Hospital, we have interventional radiologists who are able to actually do this, but then the only challenge is that there are few and the patient load is quite high. So we need more of these interventional radiologists to come and give this intervention. As you can see, just that relief can double the 5-year overall survival of these patients. So for patients with renal function compromise, cisplatin is generally contraindicated. And cisplatin, as we know, one of the toxicities is, chronic renal insufficiency or nephropathy. So cisplatin is generally contraindicated in patients with chronic kidney disease and severe baseline neuropathy. And for these patients, there's an alternative of giving weekly carboplatin at an area under the curve of 2. So these patients, before you either withhold the cisplatin or you give them an alternative regimen, you should ideally work them up for what is potentially correctable. And up to 30% of patients who have received either ureteral stenting or nephrostomy tube placement have actually shown normalization of renal functions. But then the rest generally still have deranged renal functions despite the renal diversion. So in case you have these patients who generally improve on renal diversion, then they should ideally get the CCRT with cisplatin-based chemotherapy. So there's a study done by Nam et al. In 2013, and this study was generally to assess the activity and toxicity of giving primary CCRT with carboplatin vis-a-vis, the usual cisplatin-based chemoradiotherapy. And the focus here was on patients with ECOG status of 2 or 3, and most of these patients had deranged renal function. So in terms of outcome, overall uh, response rates of 99% were seen in the carboplatin group and 88% in the cisplatin group. But then in terms of 3-year and 3-year progression-free survival and 3-year overall survival, it was generally comparable. So there was no really much significant difference also in terms of the serious toxicities. So the conclusion from these authors was that carboplatin can still be better tolerated than cisplatin, especially in patients who have poor general condition because of deranged renal functions. Those are patients with ECOG status of 2 or 3. So there's a study that was published in March, that is like a month ago, that also tried now to look at the role of immune checkpoint inhibitors, because currently pembrolizumab is being introduced in almost all gynecological cancers to try and see, and that is based on the studies in other cancers that are shown better outcomes when you add the immune checkpoint inhibitors. So there was a study that was done by Lorusso et al. And published just the other day. And the aim was to assess whether adding pembrolizumab now to cisplatin-based concurrent chemoradiotherapy will be able to give better outcomes and safer profiles for these patients. So it was an RCT done between June 2020 and December 2022, and they recruited around 1,000 patients, randomized 529 to pembrolizumab plus chemoradiotherapy and 531 to placebo plus chemoradiotherapy. And in terms of outcomes, as you can see, addition of pembrolizumab gave a superior 2-year progression-free survival and a superior 2-year overall survival. However, of note is that there were higher grade 3 and 4 adverse effects with addition of pembrolizumab, and generally I think around 1.4% fatal adverse reactions from just the addition of pembrolizumab. So pembrolizumab was FDA approved in January 2024 for CCRT, that is in combination with cisplatin-based chemoradiotherapy. However, I think in our setup, we are still not yet there. The main challenge being the cost. I think a dose of pembrolizumab is almost $500,000. So you can imagine if you get it at a discounted price, it will be around 300,000, and it is still not yet universally covered by most of the insurers. So you have to really balance the cost vis-a-vis the risks. As you can see, it has a very high grade 3 and 4 side effects vis-a-vis now the benefits that you want to accrue from addition of that drug. So that is all about chemotherapy. On the radiotherapy side, we usually combine external beam radiotherapy with brachytherapy. And combination of those two gives or maximizes locoregional control. And this is actually the mainstay of treatment for locally advanced cervical cancer. We only add chemotherapy as a radiosensitizer, though it has some other minimal effects on tumor progression and the chemotherapy bit of it in terms of the cell kill. However, for locally advanced cervical cancer, you need to actually give the patients radiotherapy. So the primary goal is to just control the local disease and shrink the tumor enough. This is now for external beam radiotherapy in order to give the subsequent brachytherapy. So the standard dose is usually 45 to 50.4 grays to the whole pelvis, but then you can actually boost up to 60 grays, especially if you have persistent tumor or a very bulky tumor that doesn't really respond within these confines of 45 to 50 grays of radiotherapy that you give. So this radiotherapy is actually for those who have been able to interact with these patients or in these setups, we give it at 1.8 to 2 grays per day. That is 5 days a week for around 25 days. So for these patients also, they get weekly cisplatin at 40 milligrams per meter squared as a radiosensitizer. So if, let's say, the patient is getting cisplatin every Monday or every Wednesday, then every day they get now the EBRT at 1.8 to 2 grays to give them a cumulative dose of 45 to 50.4 grays for the whole pelvis. There are several techniques to give the EBRT, including the conventional 3D conformal radiation therapy and IMRT. I think Dr. Opakas will delve more into that. So these are some of the fields for EBRT. I think I'll leave those two also. Dr. Opakas will probably talk about them. And currently, I think the world has moved more towards the linear particle accelerators. Previously, and low resource limited centers, they use the Cobalt 60 telepathy machine. So part of these Linux include the IMRT and the last one there, the stereotactic body ratio therapy, which is actually the cyber knife that was launched at KU Teaching and Referral Hospital. And the advantage of having these stereotactic body radiotherapy is that you can be able to actually give precise doses, because you see, the other radiotherapy machines, generally, you have exposure to the organs at risk. But then when you're giving now these precise Linux, then you're able to target the tumor itself. So you can be able to map the tumor via imaging. And so the radiation is generally directed to the specific tumor. So you are able to protect all the other organs at risk from injury. And it's also useful, especially when you're giving the para-aortic node boosting or doses to try and just do local control. There's the issue of the tumor volume, whereby it is affected by either patient movement, peristalsis, whether the bladder fills or empties. There are several factors that might shift the position of the tumor. And if you're using the old model of radiotherapy machines, then you might be able to either move the tumor from the radiation field, and then you find yourself irradiating and exposing the other organs that ideally should not be within your field to the radiation effects. But then when you use the linear accelerators and when you use these fine stereotactic and image-guided or intensity modulated radiotherapy machines, then you are able to direct, and for example, the CyberKnife is able to conform to patient movements in real time. So in terms of brachytherapy, This one is administered now to maximize on local control, and it allows for a higher dose of radiotherapy to the cervix while sparing the surrounding normal tissue. So the total combined dose of EBRT plus brachytherapy ideally should be within 82 to 90 grays. But then I think Dr. Opakas will shed more light to that. So there are different dosing systems for brachytherapy. We have the low dose rate, we have the high dose rate, we have the pulse dose rate. So in terms of the low dose, a dose of 30 to 40 grays is prescribed in 1 or 2 sessions. And then for high dose rate, usually we employ a dose of 5.5 to 8 grays given by 3 to 5 weekly fractions. So there have been studies to now compare the benefits that you accrue from adding the brachytherapy. One of the challenges we have is that for some patients, they are unable to complete the full therapy. So they get the concurrent chemo and radiation therapy, that is the EBRT, but then you find that their insurance is unable to cover for the brachytherapy. So some of these patients will actually default on the brachytherapy. So there are studies that were trying to look at whether, is brachytherapy really necessary? Does it give you any survival benefit? Or is it something that you can actually have as an option? So Hanke et al. Looked at this in 2013, and he looked at the trends in the brachytherapy use for cervical cancer in US. But then of note is that during this period when he was conducting this study, this where now the IMRT was introduced. So most centers were actually moving away from the external beam radiation therapy plus brachytherapy to now the intensity modulated radiotherapy. So out of these patients, the over 7,000, 63% received both EBRT plus brachytherapy, and then 37 received only EBRT alone. And in terms of outcome, you can see that the patients who received the external beam radiation therapy plus the brachytherapy had way superior cancer-specific survival at 64% as compared to 52% for patients who just had EBRT alone. And in terms of also the 4 years overall survival, you can see the patients who received brachytherapy had actually superior 4-year survival as compared to patients who only received EBRT. So the message here is that for our patients, the brachytherapy ideally should be compulsory, because as you can see, it gives them an overall superior survival benefit as compared to just getting the EBRT alone. So hopefully the stakeholders in most of these insurance firms will be able to put that into consideration. So in terms of timing, how long should a patient take throughout this treatment? One of the other main challenges that we have as a country is that you can be able to diagnose, you take the biopsy, you diagnose the patient as having cervical cancer. But then the time from diagnosis to treatment, actually, if you start from the time of diagnosis to the time this patient will actually get to the point of care, most of these patients will take even 2 to 3 months before they can be able to now get to the point of care. And then now from the time they get to the point of care to the time when now they'll be able to be scheduled for the treatment that they're supposed to have, which is CCRT, most of our centers have a waiting time of almost 8 to 9 weeks. So once they start treatment, as I said, we have challenges with the medical cover, we have challenges with anemia, bleeding, we have challenges with renal functions correction. Patient comes with hydronephrosis and we are unable to have renal diversion on them. So what will be the ultimate or the optimum treatment timing to ensure that these patients don't lose out on the benefits of the treatment that they're having? Because the treatment in itself is quite expensive. So as we had said, brachytherapy is ideally initiated when the EBRT has had or the patient has had optimal tumor reduction while they're undergoing the EBRT. So if you look at the importance of completion of chemoradiation, ideally the teaching is that treatment should be completed within 8 weeks, that is within 56 days. And if these patients go beyond 56 days, then it has been shown from several studies globally that this leads to a higher rate of disease progression. So you find a patient here has completed the CCRT, which is very expensive, But then when you review them in the first 3 months post-treatment, they have disease progression. So as you can see from the study by Song et al. In 2013, completing treatment beyond 56 days has been assured with that 26% higher risk of disease progression as compared to just 9%. And then in terms of pelvic control rates, then you have lower pelvic control rates, and this is at a rate of 0.7 to 0.85. That is almost 1% per day. So in terms of pelvic control, you lose 1% per day after the 56 days. Then in terms of overall survival, there's a reduction of 0.6%, which is significant when you're talking about cancer. So that is why we try and conform our treatment to be within the 56 days that is ideal for these patients. So there have been studies after this to try and see which other mitigating factors can we add to try and just improve on the outcomes of these patients. So there was a study known as the Outback trial, and this one was done in 2023. It was published in 2023. And the aim of this study was just to establish whether adding adjuvant chemotherapy, you see, after a patient has completed the CCRT, if you add them adjuvant chemotherapy, will they have any benefits in terms of survival? So 926 patients were enrolled, and in the chemotherapy group, 461 patients were assigned, and then the patients who received adjuvant chemotherapy, that is after the CCRT, they were around 465. So in terms of outcomes, the patients who only received chemotherapy during the CCRT alone, as you can see in terms of 5-year overall survival, it was comparable to the patients who had adjuvant chemotherapy, that is patients getting the CCRT with cisplatin, and then after that, they are given adjuvant chemotherapy after. That is around 4 cycles of carboplatin and paclitaxel. But then in terms of the serious adverse effects, that is grade 3 and grade 4 side effects, you can see the patients who had adjuvant chemotherapy had, a higher side effects in terms of toxicity. And the conclusion was that adjuvant chemotherapy, that is carboplatin paclitaxel, generally will increase your short-term toxicity without any improvement in the overall survival. And from this conclusion, the recommendation was that adjuvant chemotherapy should not be given for patients who are undergoing concurrent chemoradiation. So around this time, there was also another study that was being conducted by McCormack et al., and it is known as the Interlace trial. So this was also conducted and published in 2023. So when Outback was looking at giving adjuvant chemotherapy after CCRT, the Interlace was looking at giving neoadjuvant chemotherapy prior to CCRT. And the aim was to assess whether giving 6 weeks of induction chemotherapy before the standard chemoradiation therapy would improve on progression-free survival and overall survival in patients with locally advanced cervical cancer. So out of this, they recruited 500 patients from 5 different countries. And the study was done between November 2012 and November 2022. So these patients were randomized 1:1. There was the patients who just had chemoradiotherapy alone, that is with 5 cycles of weekly cisplatin, vis-a-vis the patients who had induction chemotherapy with weekly carboplatin at area under the curve of 2, plus paclitaxel, followed by the same chemoradiotherapy in 7 weeks, in week 7. So the median interval from the induction chemotherapy to the chemoradiotherapy was 7 days. So they had a 7 days break. So you complete your chemotherapy, the induction, and then 7 days later, you begin your CCRT. And then the median overall treatment was around 45 days for both arms. And if you look at the outcomes, you can see that the patients who had induction chemotherapy plus now the standard chemo and radiotherapy had superior 3-year progression-free survival, superior 5-year progression-free survival. They had superior overall survival both at 3 years and at 5 years. And generally, the side effect profile was increased, but then these were generally from urological symptoms and they were not significant. So the conclusion was that induction chemotherapy followed by chemoradiation therapy will significantly improve the progression-free survival and the overall survival in patients who have locally advanced cervical cancer, and should actually be considered as a new standard of care. So this study is unique because questions ensued whether this can be applied in our setup. And as I'd said earlier, most of our patients have very long delays from the time of diagnosis to the time when they can be able to get an audience with the healthcare provider who can be able to manage them. And then after the treatment planning, most of these patients have like a 8-week or 10-week delay because of the queues and the waiting times in our public facilities. Then we also have the treatment interruptions that most of our patients have because of either anemia, bleeding, and all those complications that they have. And the inability to get certain interventional services such as the nephrostomy tube insertions or stenting. And then, with the poverty levels, majority of our patients are also unable to afford some of these treatments, and majority also still don't have the National Social Insurance cover, that is the NHIF. And in case they apply, by the time now you tell them this is the treatment that you need, they have like a 2 to 3 month waiting period. So during this time, there's still progression. If they are bleeding, there is worsening of condition. So the question is, will this interlace trial be of benefit in our setup, considering all these factors? Maybe that is something that we can have as a ponder amongst ourselves and see whether it could be able to provide some form of a bridge between diagnosis and treatment for our patients. So in terms of post-treatment surveillance, the median time to recurrence for these patients with locally advanced cervical cancer ranges from around 7 to 36 months after the primary treatment. Therefore, clinical follow-up for these patients in the first 2 to 3 years is mandatory, and it is very important. So in terms of the routine follow-up visits, it's recommended that you follow them up every 3 to 4 months for the first 2 to 3 years, and then every 6 months until you achieve 5 years of follow-up. And then after that, then ideally you should be able to follow up these patients annually for life. So the follow-up regime includes history taking, comprehensive, and clinical examination to detect whether these patients are having complications of the treatment. Remember, radiation therapy, especially the brachytherapy, has adverse effects, especially locally, leads to vaginal stenosis, can lead to fistula formation, So you should be able to assess all these symptoms each and every time the patient comes. And then there's also the implications on the psychosexual morbidity for these patients. And you should also be able to assess whether you're having recurrence. Routine imaging is not indicated in this clinical follow-up for these patients. But then if you suspect recurrence, then you can be able to perform or to request for imaging. And then of note is that you should be able to put into consideration women who are less than 50 years old, who have been able to get ovarian failure because of the effects of the radiation. And these patients, if they need menopausal hormonal replacement therapy, then they should be able to be provided with the option. So in terms of prognosis, the major prognostic factors for locally advanced cervical cancer include the stage, the nodal status, the tumor volume, the depth of cervical stromal invasion, the lymphovascular space invasion, and the histological type and grade of the tumor. So in terms of 5-year overall survival by stage, for stage 1B, it's usually around 80%, stage 2A, 63%, stage 2B, 58%, stage 3 goes as low as 30%, and then stage 4A as low as 16%. There are studies that have shown that patients who are HPV positive have better overall survival than those who are HPV negative. So finally, I'd want us to look at advanced or metastatic cervical cancer, that is stage 4B, CS cervix. So these are patients who have the tumor that has extended beyond the pelvis, and we have distant metastasis. So it is usually uncommon at initial diagnosis. I think for us who run the clinics, then you can be able to attest that, it's not so many patients that present at first with already advanced metastatic cervical cancer. But then for the patients who have been treated and completed treatment, they develop metastatic disease up to 15 to 61% of them will actually develop metastatic disease within the first 2 years of completing treatment. And this is why I was reiterating the importance of patients sticking to the follow-up schedule, especially for the first 2 to 3 years. So when you have advanced or metastatic disease, cervical cancer, then it portends a poorer prognosis. And the median overall survival with distant metastatic disease is around 7 months. So for these patients, treatment is usually with palliative intent, and you provide them, the best supportive care. That includes the holistic, spiritual care, palliative care, so you just make the patients very comfortable. We use chemotherapy to palliate any symptoms that they may have. Chemotherapy is not compulsory, especially when you're giving it with palliative intent. Ideally, you should be palliating the symptoms that the patient has. So if your patient is asymptomatic, then generally you do not need to put them on chemotherapy. So for patients who are symptomatic, chemotherapy has been shown to do well in terms of palliating the symptoms and prolonging the overall survival. So there's a role for radiation therapy, especially for patients who are having vaginal bleeding that is protracted. For patients who are having pelvic pain, especially the ones who have bone metastasis, then radiation therapy usually helps with palliation of the symptoms. Otherwise, for these patients, you should also be open to recruiting them to clinical trials that are available at that specific time. So the estimated prevalence in terms of metastatic disease, this is as per Hong J. Hatch et al. Publications in 2024. Number one is the pelvic and parotid. He treated these ones as, metastatic disease to the nodes. And then after the nodes, the second most common is usually the lungs. And that's why at first workup of these patients, we have to do a chest X-ray or chest imaging to just rule out any lung metastasis. Then the liver, peritoneum, and we also have this area that most people don't really put a lot of consideration on, but it is quite important. And these are the supraclavicular nodes, also called the scalene nodes. And you can see they are as high as 14%. So you can find a patient presenting with a node, especially on the left supraclavicular area. So it's really important to biopsy this node to just rule out metastatic disease. And it has been shown that these patients might just present with the scalene node with probably not even any evidence of enlarged pelvic or parotid nodes on imaging. And that is why it is quite important to biopsy any suspicious lesion that you come across. So if you find a patient having isolated metastatic findings, especially on imaging, then the most ideal thing will be to do a biopsy. For cervical cancer, it's usually a biopsy-proven diagnosis. So that means, ideally, for patients with any suspicious lesion on imaging, before you condemn them to, having stage 4B or metastatic disease, ideally you should be able to biopsy. Because there's a very high risk that this patient might actually be having a second primary malignancy that is totally different from the cervical cancer that you're dealing with, or they might be having a benign process, especially for patients who have a history of TB. From imaging, you might see some calcification or suspicious nodules, either in the liver, either in the lungs, or even in the nodes. If they had nodal TB, usually the sequela gives you enlarged nodes 10 years after treatment. So from imaging, it will not really be accurate enough, and most radiographers will have it challenging to actually conclude whether they're dealing with a metastasis or it's probably just a sequela of past tuberculosis. So that is why it is quite important, especially for patients who come from regions where you have a high HIV burden, a high TB burden. Then it will be important to actually just biopsy to prove that you're actually dealing with tumor. There was a study done by Lim et al. In 2010 for patients who had suspicious lung nodules on imaging. And he actually found out that 29% of these patients actually had primary lung cancer. So this actually reinforces the importance of just having a biopsy-proven diagnosis for these patients. So an alternative will be to do an FDG PET scan, which has been shown to be, having an over 90% sensitivity and specificity in terms of identifying distance metastasis and even lymph node involvement. So currently, This as per the current NCCN guidelines for treatment of locally advanced cervical cancer. For treatment of metastatic cervical cancer, that is stage 4B, ideally you should give platinum-based combination therapy. So in our setup, we use carboplatin and paclitaxel. But then for patients who do not have any contraindication to cisplatin, then cisplatin still has a bit of superior effects than carboplatin. But then in terms of safety profile and, you are now palliating the patient, I don't want to tip them over to the complications that are associated with cisplatin, then combination of carboplatin and paclitaxel is what is preferred for palliation. But then you can be able to add either bevacizumab, which is an angiogenesis inhibitor, or an immune checkpoint inhibitor like pembrolizumab, if you have the resources, if the patient can afford, and if you think the benefits will outweigh the complications from addition of this medication. So there's a study that was done to compare the combination of either giving carboplatin plus paclitaxel or giving cisplatin plus paclitaxel for metastatic disease. And as you can see, in terms of the outcomes, there were similar overall response rates from either giving cisplatin or carboplatin plus paclitaxel. And then there was still no difference in the overall survival. So that is what actually, developed the practice of now using carbotaxol for palliation vis-a-vis cisplatin. So there's been a study done in terms of now the addition of bevacizumab in the treatment of cervical cancer. And this was the GOG 240 that was published in the New England Journal of Medicine in 2014. And in this study, they assessed whether just adding, bevacizumab to the chemotherapy, palliative chemotherapy of cisplatin plus paclitaxel, whether it will give a better overall survival than just giving the chemotherapy alone. And you can see the addition of bevacizumab added a median overall survival of 3.7 months. And there was a response rate of up to 48%. So as I said earlier, you just balance. Bevacizumab is also expensive. Per dose, it's almost 100,000. So you balance the benefits that you will get from addition, or even this median 3.7 months overall survival vis-a-vis the cost and vis-a-vis the other setups that you have for the patient. So finally, there was the Keynote 826 study. As I'd said earlier, pembrolizumab is currently being, studied in addition to every other modality of treatment to try and see if you can actually derive better outcomes for our patients. And this Keynote 826 was a phase 3 double-blind trial of pembrolizumab 200 milligrams or placebo once every 3 weeks, plus platinum-based chemotherapy with or without bevacizumab. So the addition of bevacizumab for this one was optional. So generally, for this study, they were adding pembrolizumab now to the standard of palliative chemotherapy. And the results were that pembrolizumab gave a superior median overall survival of 12.1 months as compared to just giving placebo plus the chemotherapy. So if you are able to afford, as I'd said, pembro is almost $500,000. So if you're able to afford and the patient is motivated and you think the benefits will outweigh the risk, then as per NCCN, you can be able to recommend addition of pembro in your palliative care patients. I think with that, I come to the end of my presentation. Thank you very much. Back to you, Dr. Amina.
Thank you very, very much, Dr. Gabriel Ouma, for that quite insightful presentation. We have learned, and I believe we have also unlearned quite a number of things. And as we continue to explore the challenging management of locally advanced and metastatic cervical cancer, it is now my privilege to welcome our next esteemed speaker. So Dr. Opakas is going to give us or talk to us a little bit with regards to radiation therapy to our patients who have locally advanced cervical cancer, and even the patients who have metastatic disease who can really benefit from radiation therapy, and really what can we do for them with regards to radiation oncology. So a few wise words, Dr. Opakas, welcome.
Thank you, Amina, for your very nice introduction. And first of all, I must congratulate Dr. Gabriel Ouma. He has done justice to this topic, and there's nothing more I could add except a few points. And he has really made my work completely as easy as possible. So first of all, I would wish to just give an overview about radiation treatment. He had presented slides about the doses, so I'm not going to do the same. But one of the things which I wanted to clarify is that for most targeted treatments, we usually prefer using linear accelerators. And the reason why we're using that is that we're able to give what we call fractionation. Dr. Ouma talked about we give between 25 and 28 treatments of external beam radiotherapy over a period of time. And that is usually the standard of care that we do. Why do we do this? Because we want to break down each treatment to give a lethal or sublethal dose, which can actually, the sublethal dose can actually be turned into lethal by administering the cisplatin chemotherapy. Standard linear accelerators are what we use. I know in KNH they have one. In Moi teaching and referral, we have a CyberKnife. No, we don't have a CyberKnife, but we do have a linear accelerator that is called a TrueBeam. I think it's the highest end of linear accelerators that we have. But there's no much difference if you have even a vital beam, which I know most of the centers in Nakuru, in Mombasa, and in Garissa do have. What is very important is the level of technology that we apply and deploy to target this disease. Just another clarification on the type of equipment that we do have. When you talk about SBRT or the CyberKnife, CyberKnife may not be the tool that we will want actually to use for cervical cancer treatment, specifically because we use this for stereotactic body radiotherapy, whereby we give between 3 and 5 sessions of radiation to target very, very small tumors, typically in the brain. Typically, you'll find these tumors in the spine, or sometimes you may have some pancreatic tumors, or you may find some oligometastatic disease, whereby you have a small tumor in the lung, which needs to be obliterated, or you may have a very small tumor in the liver, which may need the same for obliteration. So we will actually spare that for the CyberKnife. Incidentally, also, if you have a higher version of equipment, I know like in some hospitals in Nairobi, and also here in Moi teaching and referral, we can actually use a linear accelerator to achieve the same. So for radiation treatment, standard of care, we want to thank all those involved in running our centers in the country. Standard linear accelerator with good treatment delivery techniques between 3D conformal radiation treatment, and in some cases where you want to treat paraotic nodes, you may want to deploy more advanced techniques such as IMRT. That being said, I think we have a challenge in terms of access to care. And as Dr. Ouma talked, our main goal in the treatment of cervical cancer should actually be prevention. We should not be having patients walking into our clinic. We need to look at countries like Australia and Sweden. Those Nordic Scandinavian countries have done a very good job in terms of cervical cancer prevention. However, another discussion which we've been having, because when a patient comes through our clinic and you open the door, you have 50 patients. and Dr. Ouma and Dr. Amina can attest, because Dr. was with us here at Moi Teaching and Referral when she was doing her gynaecology. You will sit in a clinic, see 50 patients, book that patient for treatment, and you find that they have to wait between 6 weeks and 10 weeks. And we've been doing this for patients who are fit for treatment, although it was not standard of care then. We had to actually consider giving neoadjuvant treatment. And I would like to say that the Interlace trial in our situation has actually answered some of these questions. In those more developed countries, they were actually doing it as a study. In Kenya, we are doing it as a necessity. So we did it because we could not have quick access to radiation treatment. So it's something that we need to look at and encourage the multiple centers to develop protocols for neoadjuvant chemotherapy prior to concurrent chemoradiation, which follows afterwards. I'd like to quickly mention some of the side effects of radiation treatment. There's a lot of myth around it. And we've had cases whereby patients actually even refuse to start treatment because they say that, oh, so-and-so aliingia kwa hiyo machine and they never made it, or that machine has some side effects, or it's a dangerous equipment. They actually talk about kuchoma, and they equate it to being electrocuted, that, putting a patient on the equipment, the radiotherapy delivery systems is being equated to being electrocuted. But this is something that I think as medical practitioners, starting from the primary healthcare, where we do a lot of screening, we need to demystify. In the county referral hospitals, we also need to demystify this. Yes, the radiation treatment itself comes as basically an X-ray, high energy X-ray, which is delivered in a very highly planned system to target the tumor. So the patient has a scan, a treatment planning scan, which is done. And then we do target the tumor. In this case, cervical cancer, we do target the pelvic lymph nodes. In some special circumstances where the patient has paraortic nodes, we do target that also. And therefore, when we target, sometimes we may have some dose drop off in other organs. And generally, we will look at systemic toxicities. We have gastrointestinal toxicities, we have genitourinary toxicities, and local toxicities, especially when you're talking about the vaginal involvement. So the gastrointestinal toxicities, usually you will have gastroenteritis, so the patient may develop diarrhea. And these ones we manage in the normal way. We'll manage most of the diarrhea which we get in other non-infectious conditions. We use atropine injections where it's very severe. We can use loperamide. And in some cases, we do tincture of opium. And where it's becoming chronic, we can use octreotide and oral sulfalazine. And we do encourage patients to take probiotics when they get the radiation treatment, because we find that it actually tends to improve their tolerance to the radiation. Some patients during treatment develop proctitis. Proctitis is where the rectal mucosa is severely inflamed. We use local steroids and local anti-inflammatory suppositories. So sucralfate is also another agent that we use, and you can use it locally. So when we talk about the GU toxicities, that's usually the bladder, and patients will present with this. And the most common one, when the patient is getting the radiation, they'll come typically in the 3rd and 4th week, they'll present with acute radiation-induced cystitis. And that's the patient to start complaining about when I pass urine, it's really burning, I'm having a lot of pain. And you'll encourage that patient to take non-steroidal anti-inflammatory agents as long as the patient doesn't have renal issues. We also do consider antispasmodics and anticholinergics, basically oxybutynin, buscopan. And funnily enough, you can actually encourage your patients to drink cranberry juice. So cranberry juice is what I encourage patients to take during their chemoradiation, especially to the pelvis, be it for gynecological or rectal cancer. We do encourage them to take that as much as possible. And in terms of brachytherapy, Dr. Ouma has done a lot of justice to that topic. What I will add is that when we do treatment with brachytherapy, different centers have different protocols. You may have, and also different equipment for delivering brachytherapy. But the whole idea is that we are unable to deliver a total dose of 85 to 95 gray from an external beam perspective. Why? Because we have your neck of femur in the way, and beyond 50 gray, you may actually develop necrosis and fractures. You have the rectum in the way, and beyond about 60 gray, you may start developing complications, proctitis, even the risk of fistula is actually true. So how do we deal with that? We do fractionation. You can do all the way between 2 fractions to 5 fractions. There are some centers which do 7 fractions. So what is fractionation of brachytherapy? We typically use a high dose rate in this country. I don't think we have any center that is giving a low dose rate. And high dose rate, you are able to treat more patients. It takes a lesser time. Typically, a treatment will last between 5 minutes to 20 minutes, depending on the age of the source. So you will have that. And we do, in Moi Teaching and Referral Hospital, we do 2 fractions. The reason being, number one, resources in terms of human resource, in terms of financial resources, and in terms of also the materials which we do use. When you compare the treatment 2 fractions of 9 gray to maybe 5 fractions of 5 gray, or maybe 7 fractions of 4 gray, so far we've treated, and we are going to do a paper on that. Our outcome is actually similar. Our rate of complications anecdotally is more or less not inferior. We don't get more complications so far, but we do actually get a lot of good outcome. And the reason, our driving factor at that point in time was financial, because patients really could not afford to pay for the 3rd fractions or more. One of the complications you may get from brachytherapy and also external beam, you may actually get acute vaginal mucositis. We encourage patients when typically in their 4th or 5th week to go for sitz bath. That means you get some warm, salty water, saline water brine, and they sit on it for maybe 2 or 3, for 20 minutes or 30 minutes. And in some severe cases, we actually dilute the hydrogen peroxide. You dilute it to about 10% strength, and then you can actually use as a douche. We have local anesthesia in very severe cases of mucositis, benzidamine, or any other local anesthesia which you can apply. We do it for pain control. And some patients actually do get ulceration and necrosis, which we apply that, the local anesthesia. And one of the rare and more complicated side effects of treatment is fistulas. You will notice that most of these patients who get fistulas were actually stage 4A. More than 70% of these patients will be with fairly advanced local disease. That means that the tumor had gone into the bladder, and that the tumor had gone posteriorly into the rectum. So for such, we usually do conservative management. We do we actually give them hyperbaric oxygen if they can afford to get that, and pentoxetylene, which is actually very good. One of the things which I advise patients is that they need to do vaginal dilatation whenever they get their treatment. How do you do that? There are vaginal dilators which are in the market. Most patients may not be able to access them, so we actually just advise them to get a candle and a condom. So they different sizes of candle and different sizes of condom, and then they'll use that to dilate the vagina. This is very important, especially patients who are young and they still have a sexual life ahead of them. I'll stop at that because of time and maybe take one or two questions. Back to you, Dr. Amina.
Thank you very much, Dr. Opakas, for such a wonderful, wonderful talk. I think we should not sit here again and probably talk of locally advanced cervical cancer or even metastatic cervical cancer. And why do I say that is because we should be preventing cervical cancer, right? So let's improve on vaccinations. Let's improve on screening. Let's improve on picking these women early when they still have pre-malignant disease and be able to offer them the treatment, the appropriate treatment that they need. However, sometimes that doesn't happen in our setup. Majority of our women will come with locally advanced, they come with metastatic disease, but many times when they come to us, we offer them multimodality treatment and they don't need. So do we ever stop and ask ourselves whether the treatment we are advocating for benefit the patients we treat? Do we ever stop and ask ourselves, hey, am I doing more harm? I mean, there are patients who come with stage 1B3, they come with stage 2A, 2B, and unfortunately, you find these patients have already had surgery done. So at most, these patients will have had either subtotal hysterectomy or they will have just had a simple hysterectomy, but then they do have disease in the margins, they have disease in the vagina, you cannot imagine. So we need to stop and say, let's do good for these women. If we've not screened them, if we've not vaccinated them, then when they come to us with locally advanced disease, let's offer them a single modality treatment, which is concurrent chemoradiation therapy or just plain radiation therapy, depending on the patient you get, right? So with that, I think I want to just dive deep into the questions and let me, there are quite a number of questions in the Q&A box. So I'll take a few for each. So the first question, Joseph asks, what is the cost for the vaccine? And that should be the HPV vaccine. And why did the government not use schools to administer to all girls? So what is the cost of vaccines? Gabriel, do you want to probably take that? So the cost of the HPV vaccine and why the government uses schools to administer to all girls and probably not, why isn't it clinic-based vaccination?
Maybe I can just take that quickly. I think HPV vaccine is available in all public hospitals in Kenya. I think at least when you talk about county referral hospitals, we talk about national referral hospitals, it is available. And I will just advise Joseph, if you have a child, a young adult, or even the adults who qualify, because you know up to 28 years, if they are HPV negative, they can actually be administered, they can receive the vaccine. You can actually walk to your nearest county referral hospital. And if you have any challenges, I believe all the national referral hospitals and the regional centers can administer this vaccine at no cost to the patient or to the client. Thank you.
Thank you very much, Dr. Opakas, for that. Just to reiterate what Dr. Opakas has just said. So commonly we have Gardasil 4 that is clinic-based. we hope probably in the future that it is going to be a school-based vaccination. And the reason being that most of these girls, the target age group are girls who are school going. So most of them will not go back to the clinics for vaccination. So if it is at the schools, then it is easily accessible to most of these girls, and hopefully in the future, the boys. So Gardasil 4 comes at no cost. The only problem then, again, is the age at which the vaccination is given, which is 9 to 14. But however, remember that again, up to the age of 26 and more than that, up to the age of 45, these young girls and women can still get vaccinated, and Gardasil 4 is free. What is kind of costly is the Gardasil 9. That's usually not really easily accessible to most women, and it does cost. It is quite pricey. It comes to about 40 to 45,000 shillings. You can get that at a number of private clinics or hospitals, Gertrude being one of them. But then remember what Dr. Uma said, that a single vaccine, so be it the bivalent, the quadrivalent, or the nonavalent, then the outcome is pretty much the same in a number of studies that have been done, and that is what is currently what is being advocated for. So it doesn't matter which vaccine you get. Important is you get vaccinated. Thank you. So I'll take another question. So Beatrice asks, say you meet a patient who is 28 years old and has not had any sexual activity. Can this patient receive the HPV vaccine? I think we just answered that. So yes, Beatrice, that patient or that young lady who is 28 can get vaccinated. So I'll take one more question. So Kennedy asks, how do we capture? I'll take one more question after this one. How do we capture the clients with lesions and treated surgically, either via colonization or a hysterectomy? Dr. Omar, would you want to take that? How can we get these patients early and offer them treatment?
Thank you very much, Dr. Amina. I think the question on how we can capture clients with lesions and be able to treat them early is basically just increasing the uptake of screening, because screening is currently free and it's available in almost all level 4 hospitals and above, actually from the level 3 going up. So you should be able to get free cervical cancer screening in basically all healthcare facilities that you walk into. So if we can be able to encourage ladies, especially who are now beyond the vaccination age bracket, so ideally, more than 25 years and above, if you can be able to encourage them to generally uptake or embrace routine screening, then you can be able to capture most of these lesions quite early and be able to actually treat them with a curative intent. Of note is that there are countries like Australia, Canada, Scotland, where they rarely see locally advanced cancers. And you find even the senior most of gynecologists, when they come around, and they get actually shocked by the number of locally advanced cancers that we have here. So it just shows how much the strategy of vaccination and screening can be able to lower cervical cancer cases. It's one cancer that is curable, and it is actually, from data that I've actually shared, almost 100% preventable through vaccination. So we are able to capture these lesions quite early and treat them. Thank you.
Thank you very much, Dr. Omar. I'd just again like to reiterate what Dr. Omar has said and just add that I believe a number of the gynecologists are in the group or attending the webinar today. What we usually do in our setup is most of the times we do outreaches. So say, for example, the team that's based at MTRH do outreaches to a number of AMPACT clinics. So they do go to Busia, they go to Chulaimbo, they go to Webuye, and if you tried and said, for example, each month I will do an outreach, a nearby center, even once a week, once a month, it doesn't matter. Eventually, you'll have achieved a lot and you'll do great. So let's do outreaches. Let's screen a lot of the women. Many times because most of our women are young, the women who are coming with advanced disease. So most of them, you are able to do visual inspection with acetic acid or for them, and it's not really complicated. So you don't really need to delve into doing pap smears, HPV, if they cannot afford. I mean, if you have a patient who can't afford whatever screening method you need them to do, then you do what is possible, what is accessible, what is easy for you. And eventually, I believe we'll be able to do a lot of good in our setups. Let's give back. Let's do a lot of outreaches. Let's get these women early. It's the only way you'll be able. And let's vaccinate, as Dr. Ouma has just said. One last question for Dr. Opakas, and it's a question we usually struggle with. So Simon asks, old women, so 80 years and above, presenting with locally advanced cervical cancer, will they be managed just as the young women? And if not, what is the best management option for them? Dr. Opakas?
Thank you, Amina. Yeah, that's a very interesting question from Simon. So when you are, I think also Dr. Ouma presented, like when we do like evaluate a patient, pre-treatment evaluation, you have to look at the performance status of the patient, the organ function of the patient, and you have to look at, in many cases, we want to look at the 5-10 year survival of the patient. And sometimes when we look at the treatment which is given, then we have to weigh that against like how is this woman or this patient going to take that treatment. I will look at this patient and look at her function in terms of organ function, in terms of performance status. The standard of care that I will give to patients who are 80 years and above definitely is radiotherapy, but I'll be keen to consider if the patient is really, really functionally well and she's up and about, able to run up and around, in very, very few select cases, we can give concurrent carboplatin, as it had been mentioned, because of the side effect profile. But that has to be really carefully selected. But I would say that 90% of the patients I will actually just give external beam radiation and brachytherapy. And in very few select patients, we may consider carboplatin chemotherapy. And that would be quite rare, depending on the performance status. Thank you. The other thing is most of these patients, when they present at 80 years and above, you may find that they have quite bulky disease, they're bleeding. So you may want to deal with that first as we continue to evaluate the patient. But it is actually a very interesting question that you asked. Thank you.
Thank you, Dr. Opakas. One last question for Dr. Ouma. So Isatu asks, can you discuss the role of surgery in the management of locally advanced cervical cancer, and under what circumstances is it considered? Dr. Ouma, would you respond to that? Thank you.
Thank you very much, Dr. Amina. I think I'd actually placed that in one of the opening slides and actually compared surgery vis-a-vis giving concurrent chemoradiation therapy. And I remember I talked about patients with locally advanced cancer, especially I think stage 1B3 and stage 2A1 are the subgroup of patients who previously were considered for surgery. That is radical hysterectomy. Some people even consider them for, neoadjuvant chemotherapy and then surgery. But then it didn't really reduce much the incidence of high-risk factors. So high-risk factors here, we are talking about these patients having the bulky disease, being at a higher risk of having postoperative positive lymph nodes for tumor, positive margins, and positive parametrial extension of the tumor. And these factors have been shown from studies to give, like a 50% risk of recurrence and up to even 40% risk of mortality after surgery alone. So majority, up to half of these patients will end up still having the chemoradiotherapy. So that means you will put them to a trimodality treatment. That is surgery, chemotherapy, and radiation therapy. And we say that one gives them a higher morbidity vis-a-vis just putting them on a single treatment option. So there is not much difference in terms of the overall survival when you use either, but then because of just the complications that come with the trimodality of treatment, then the best will be in a scenario where you can be able to give, like in our country currently, we have several centers that offer radiation therapy. Then ideally for all patients with locally advanced cervical cancer, you should just try them towards getting the chemoradiation therapy. Eventually, more than half will end up there, whether you have done the surgery, even with the surgery, they'll end up having the chemoradiotherapy.
Thank you very much, Dr. Uma. So as we come to the end of the webinar for today, I want to extend a heartfelt thank you to each and every one of you for joining us. Yes?
Yes, there's a question down there, the chat box. I think probably it would be fine if I address.
Yes, there's so many questions.
The issue of HIV. I think someone had asked, why did I, highlight that ideally you should also just take up the serostatus and its relation to the treatment of these patients with locally advanced cervical cancer. So of note is that there have been studies that have been done even at MTRH that actually showed no much difference between outcomes of patients undergoing treatment for cervical cancer, between HIV positive and HIV negative. So if you match them, ideally, if a patient is compliant to medication, has good performance status, then the outcome generally is not significantly different between those who are seroreactive and those who are not seroreactive. But then it will be good to actually be able to know the patient's serology, because there are other complications, including some of these patients actually just get diagnosed when they come and get diagnosed for like the cervical cancer. That is the moment when you do this serology, then you can be able to pick up that actually they're also seroreactive and you put them on medication. So not being compliant or not being on any medication or not being aware of your serostatus, yet you are seroreactive, then ideally you can see that you might have poorer outcome that is more to do with your own immunity status than the HIV infection itself. So that's why it is important to look at the patient holistically and give them the support that they need in terms of management. And then finally, the question on the association between HPV and the whatever better prognosis that I talked about. So these are mainly from observational studies. So it's not something that we don't have really strong data from RCTs that can be able to say now, it is black or white. But then what has been postulated is that some of the oncogenes that are produced by the HPV, including the E6 and the E7, have been shown to degrade something called P53. So these are just more advanced information that I don't think probably it's good to know or optional. But then P53 mutation is a marker of almost majority of all tumors in the body. So you can imagine if this E6 oncogene from the HPV actually degrades it, then it has been postulated that this actually leads to the better prognosis for patients who are actually having specifically the HPV-16 subtype. But as I've said, this is not black and white. It is not backed by good data. So there's still a lot of work to actually try and find the exact cause relationship between the two. Thank you.
Thank you, Dr. Uma, for that.
Just to add on that, there was a question about can someone infect a partner with cervical cancer? You can infect someone with HPV, but cancer is not a transmissible. You cannot infect anyone with cancer, but you can infect with the causative agent, which is HPV. Same as with liver cancer, you can infect someone with hepatitis B virus. So the causative agent can be passed, can be transmitted, but not the cancer itself. And Dr. Uma has just talked very well. We see the same thing with oropharyngeal cancers that are HPV positive. It's another cancer that can be caused by HPV. And the outcome appears to be largely a bit better than those that are HPV negative. All said and done, I don't think anyone wish to get cancer as much as it's a bit better than HPV negative one. So vaccination and prevention are key. Thank you so much. Yeah.
Thank you, Dr. Opakas. Dr. Uma, any parting shots?
Dr. Amin, I think the parting shot will be we just try and fit into the WHO Global Strategy 2030. So that means if we, in a household, because the school program has been able to mop up majority from around 30% to now 77% vaccine uptake, but you can still be able to do more. So in our individual households, if you have girls within the age bracket that is 9 to 14 years who are eligible for the vaccination, then we should be able to have them vaccinated. And then if we have now ladies who are within the age group of screening, then you should be able to encourage everyone amongst ourselves to have screening. More so the healthcare providers, because these are the persons who should be able to be counseling the patients on the importance of vaccination and screening. But then studies have shown that we are amongst the population that has a quite poor screening uptake. So we should all be global ambassadors and national ambassadors, advocating against, cervical cancer and, the screening and vaccination. Thank you.
Thank you very much, Dr. Uma. We've had such enthusiastic presenters today. And apologies, we're not able to take all your questions because of time constraint. But hopefully you've been able to learn a few things here and there. The final message, as Dr. Uma said, as well as Dr. Opakas, let's vaccinate, and let us screen ourselves and our patients, our families, our neighbors, basically everybody you meet. So as we come to the end of the webinar, I want to really extend a heartfelt thank you to each and every one of you for joining us. I hope this webinar has been invaluable and you've been able to learn. Thank you again for your participation today. We hope to see you again in the next webinar. Thank you very much.